Okay. So I'm going to chat today about pediatric red-eye. We've had a few kind of talks about red-eye. Kind of approach to differential isn't too different in pediatric. I'll spare you the gross pictures of eyes because red-eye is all kind of the same. So just pretend that someone comes to emerge with their child. We'll say that they're 14 years old and they're male. What do you want to know on history? Yep. Sure. Yeah.
I want to know how old is the baby? What was his gestation? I'm sorry.
Yeah, a good past medical history.
Good past medical history.
Yeah. See what I had there. So yeah, you want to know when did it start? Does it correlate with any time of day? Is there anything in particular that sets it off? Is it one eye, both eyes? Start to one, go to both? Is it getting worse, getting better? Associated symptoms, which I think you got all of them there. Have they tried anything to treat it before? Have they been putting topical antibiotics? Because you can buy those over the counter, and has that changed it at all? Have they been trying artificial tears, things like that? Do they have past medical history of red eye? If they're telling you that every summer that this happens, and you're thinking maybe it's more of an allergic thing or something like that. Allergies. Contact use is a big one too. Kind of more specific to any eye complaints, stiff contact. Yeah, with associated symptoms in there. Physical exam wise, what would you like to do? Sure. Sure. Yeah, if you have I can do that. Yeah. If available and you're comfortable and patient. Anything else? Maybe moving away from the eyes a bit. Yeah. Yeah. Thanks. We're done. They have pupils, extraocular motions, corneal sensations important for some more high-risk infections, visual acuity, visual fields, inspection. So like Joanna said, is it the eyelids that are red or is the actual conjunctiva, inspection of discharge, plus minus slit lamp exam if you're comfortable it's there. And you always want to look in ears, nose, throat, and associated lymph nodes. So differential diagnosis of red eye, there's a few ways that you can kind of organize it. The easiest, or maybe for me the easiest, is just infectious versus non-infectious. So you have your bacterial and viral, and then your non-infectious causes, which are chemical, allergic, and actual injury or trauma, and then the weird and wonderful things that we've seen in ophthalmology that I'll discuss in a bit. In the pediatric population, some things are a little bit more common than you see in adults. So allergic, bacterial, viral, pretty common in adults and pediatrics. In the adult population, you see a lot more kind of dry eye complaints, not as common in peds. But for the most part, it's very similar to what else you see. Then you can also organize your differential by age. So neonates, they break it down in by hour and days. Kind of more historical points, the neonates less than 24 hours that had chemical ones, as they used to use silver nitrate as a prophylactic eye drop, which used to cause a lot of irritation. I think they just use erythromycin now, which causes less. And then you're thinking, again, in neonates, diphtheria, gonorrhea, chlamydia. You're getting infants and toddlers. That makes a distinction with and without ear involvement. So again, important to look there. As you kind of get more into school-age children, you're thinking more virus or viral. You should always be thinking viral and bacterial for everybody, but more common as you get older. And then as you get even older into adolescence, then you kind of add allergic stuff kind of more into the picture there. So just briefly, we'll go over bacterial versus viral versus allergic, and we'll go over some other ones. Caveat here is, and I think we all know this, is that no specific thing on history is like 100% this is viral, 100% this is bacterial. So it's kind of just to get the gestalt of what's going on, and these are just kind of commonly seen with each one. So in bacterial infections, the research is kind of back and forth apart with what's most common, bacterial versus viral. This is the number that I found. So technically, bacterial is more common in the acute setting. In the history, so it could be both eyes, it could be one eye. They'll have a mild to moderate discharge. It won't be described as tears. It'll be an actual discharge. Interestingly enough, in the research, early morning crusting was the most predictive of bacterial. So if they say, oh, they can't open their eyes in the morning, or my child has to really clean their eyes out, then you're, again, thinking maybe more bacterial. The most common microbes there are listed there. They're kind of skin microbes, plus Pseudomonas is indicated in contact use. So some red flag symptoms when you're thinking of bacterial infection is if you can see a pseudo membrane form, so an actual kind of film on the eye itself, as well as periauricular lymphadenopathy, then you're considering kind of more sinister bacterial infections in like the Neisseria family or chlamydia. In that case, it's kind of a referral to ophthalmology to kind of deal with those ones because they're at significant risk of vision loss. Your diagnosis for bacterial is based mostly on history, kind of what they tell you in physical exam. You can do like a swab and a culture if you're really suspicious of those red flag organisms. And treatment. So the important thing for bacterial and viral is they're both kind of diagnosed mostly on history and physical, and they're both self-limiting. Bacterial, it's shown that if you do use topical antibiotics, it induces remission a bit quicker, but for the most part, they are self-limiting. So if you do nothing for both, it's probably going to resolve on its own. And that's kind of, I think, the biggest takeaway from today. So yeah, you can use, you can buy polysporin drops over the counter or erythromycin if it's an infection not going away. So we'll go to the more viral side of things. So the most common viruses are adenovirus, enterovirus, Coxsackie, and varicella zoster virus. So viral tend to be more unilateral, if eventually spreading to bilateral, versus bacterial will usually present both eyes at once rather than 1 to 2. They have a little bit more associated lymphadenopathy. They'll complain of more pain and kind of a gritty foreign body sensation. And they tend to have kind of a slower onset or progression. So bacterial will be a few days versus viral may kind of onset over a week or longer than that. Again, they could present either way though. So the red flags with the viral infections is if they have kind of this recurrent picture of viral infections, you'd be worried about varicella zoster activating and then hibernating, activating and hibernating. If you do a slit lamp exam and you see those very pathognomonic dendritic lesions, you're thinking HSV. And then decreased corneal sensation is kind of along that picture. The virus has to hide in the trigeminal nerve, so they'll have decreased sensation if they have one of those infections. So again, just like bacterial, if they have these red flag symptoms, it's kind of a referral to ophthalmology to handle those because again, there's risk of significant vision loss. Again, diagnosis is on history and physical, and treatment is self-limiting. With viral ones, because they're a lot more contagious, you always want to counsel taking a kid out of school or daycare for at least a week. So the allergic ones. So again, on history, the allergic ones will be more related to triggers or times of year type stuff, and they can also have a past medical history of ACE and just other allergies, seasonal allergies, things like that. One of the main symptoms for allergic conjunctivitis is the itching, the pruritus. If that's their principal complaint, then you first that should be allergic. It tends to affect both eyes once. Should be kind of uniform, although it might affect one more than the other. And the other thing that you see is eyelid edema. So if their eyes are puffy and red, then again, thinking allergic. So they'll have a more watery discharge, and they might have mild photophobia. So the red flags for allergic ones is eye pain. They shouldn't be painful. It might be itchy, but it shouldn't be painful. They shouldn't have a significant discharge. Then you should start thinking about differential. Again, based on history and exam is your diagnosis. So the treatment for allergic one is basic eye care and education. So avoiding triggers and avoiding itching, because when you itch the eye, it'll actually cause like mast cell degranulation and will just cause more itching. So avoiding kind of stirring up the pot and avoiding triggers. Cool lubricants, so you can buy those artificial tears and you can keep them in the fridge. That's quite soothing. And then you can actually get topical antihistamine drops. They also have antihistamine and vasoconstrictor ones, so it'll clear up the eye and hopefully stop it from itching. Or you can just take oral antihistamine as well. The other weird and wonderful things. So hordeolium and chalazion. So hordeolium is a sty, and chalazion is a chalazion. Those words are often are interchangeable, so I figured I'd spell it out for you real quick. So styes are an acute infection of a oil gland. So it's like a kind of a red, painful lump, versus a chalazion is kind of just a chronic inflammation. There's usually not a bacterial component of, again, kind of the oil gland. So the way I like to think of it is chalazions are lazy, so they hang around a little bit longer, versus sty is like one syllable, quick, so it's like a red acute bump. So you want to keep that in your mind. And again, so it's kind of affecting the eyelid there, but it can cause eye irritation and redness, which is why it's on the differential. The treatment for both of them, though, is warm compress and lid hygiene. When I was on ophthalmology, one thing that they told all of their patients was to take baby shampoo on a Q-tip and just use that to clean the edges of your lids. And that's supposed to help kind of clear out all the gunk, get the oil moving, and stop it from getting backed up. And then the other side of things is blepharitis, which is just a chronic inflammation of the eyelids themselves. There's kind of a bunch of theories on what causes that. It's kind of the normal bacterial flora in the area can cause irritation, as well as gland dysfunction. It's probably a little bit of both. There's no real answer to that, but it can cause red, pretty, itchy eyes. Treatment for that is, again, education on lid hygiene and warm compress. And then the last one I'll go over, just because it's more common in pediatric patients, or maybe not more common, but kids do have active, it's corneal abrasions. So it's the chief kind of symptoms here are eye pain and photophobia, foreign body sensation, and just closing of the eye. So any pediatric patient that presents with complaints about eye and they won't open it, you should really be thinking that there's an abrasion going on there. So the way to diagnose it, if you do a slit lamp exam, you can actually put the fluorescein dye in and you'll see it'll highlight the epithelial defect, and you can kind of gauge based on how severe it is, if you think it's more than an abrasion, etc. So the treatment, so they usually do some type of antibiotics. In pediatrics, it's suggested that you use an ointment over the eye drops, because the ointment is potentially more tolerable than children don't seem to like eye drops. Another tip was to put the ointment on before bedtime or before nap time, because otherwise they'll have blurry vision and they'll be sick in their eyes because of that. In adults, they usually will do the antibiotic treatment and then they'll put like a patch on the eye. That's not really recommended in children because they'll just rip it off, and also there's really no evidence to show that that's anybody. That's a quick differential of red eye. Okay, so this is the clinical approach to the pale child, talking about how to approach a child that comes into that you're seeing with anemia. So this is a case we had on CTU 2 weeks ago. 13-year-old kerosene boy presents the emergency department presenting worsening color and weakness. His grandmother noticed a decrease in his color over the past month. Been finding himself frequently falling asleep in class. He had previously tolerated exercise well, however, last night found himself short of breath and lightheaded during a volleyball game. He was pulled out early, shows up and emerged. He's tachycardic and all of his vitals are stable. So what are some things you want to ask him? You're seeing him emerge. Yeah. And so say this was a baby. Anything else you're concerned with? Yeah. Mm-hmm. Yeah. General, some of them are said here. So if you're looking at the onset of symptoms, is this something that's shown up with the all of a sudden short of breath, feeling weak? Is it progressive or is it asymptomatic? A lot of these times the chronic processes can show up asymptomatic. The body adapts to the lower hemoglobin. Is there any color change? Are they just pale or jaundice? Oftentimes, been away for a month, came back, realized how suddenly pale he was, and decided to take him into emerge. And how are they telling exercise? Showing breath fatigue, lightheadedness, dizziness. Then you can go through their diet for older kids, looking at eating meals, eating red meat, especially vegetarian. I feel like I'm doing a very thorough diet analysis, getting into their B12 and folate levels. And then for infants, you're looking more at, are they taking breast milk? Are they drinking more cow's milk? And are they using iron fortified formula? That's important things to examine. And then also starting looking at a source of active bleeding, especially if it's an acute process. If you're on like stool changes, any sort of blood in the stool, shit, melena, dark lactose stools, do they have red nosebleed? And if it's a girl, thinking of more menstrual history. As for infants, though, oftentimes a lot of the symptoms, there won't be many symptoms. Maybe often irritability and poor oral intake, so the top two symptoms that will show up with symptoms. And then important to run through their past medical history, just looking at relaying anything, which turns out to be important in this case that we're talking about. And then also going through their family history, so getting their
ethnicity, Mediterranean, predisposed to thalassemias, sub-Saharan African, sickle cell trait disease, G6P deficiency, and then also looking at their prior blood work. So for this case, we went through. Turns out he had had a non-diagnosed lower GI bleed 4 years ago. He's still been having occasional blood in the stool, a little bit increased over the past couple of months. He also had recurrent pancreatitis and had a splenic vein thrombosis 4 years ago. And then when you get into his diet, things start making a little more sense. Every day, skip breakfast, pizza buckets for lunch, and sometimes has salad, but really not much. With how it was described. I'm not taking recycling. So these are some general things you're looking at for when you go through your physical exam. Oftentimes there's not one major symptom jumping out at you besides the pallor that you see here. So look a little more thoroughly. So in this case, you see it in the skin. We've been talking about it there in the palmar creases. Looking at their nail beds, often a later sign of the pallor in the nail beds or in the conjunctiva. And also jaundice, sclerolicterus, if you're thinking more of a hemolytic anemia picture. On abdominal exam, look for hepatosplenomegaly, and on examining the hands, you'll see choroideremia, which is the fruiting of the nail beds for anemia. GI symptoms, thinking loss of appetite, dysphagia, pica, which is the ingestion of non-food foods. As well as angular stomatitis and just inflammation and cracking you'll see on the front of the mouth, and then the atrophic glossitis should be the pale spots on the tongue that you'll see inflammation. For cardiac, a lot of the times, only when severe you'll see larger changes in the heart, such as cardiomegaly and the heart failure, but oftentimes there's a presentation of tachycardia or increased cardiac output, and then just sort of oftentimes the only complaint would be the general feeling of malaise, fatigue. So just a quick definition of anemia. Anemia is having a hematocrit hemoglobin 2 standard deviations below the adjusted mean for age and sex. For this case specifically, we'll be talking about iron deficiency anemia. The most common form of anemia in kids, and the most common causes being inadequate iron intake. Oftentimes, you have the rapid growth combined with an inadequate dietary intake, as well as a low growth rate or consumption of cow's milk. Important kids that switch to cow's milk too early, and you don't want to ask, it leads to poor intestinal absorption of the cow's milk, as well as cause minor GI bleeding. And a quick review of your MCV, anything below 80, you're looking at microcytic anemia, microcytic anemia. So anyone with your iron deficient anemia, are you microcytic? So probably not going to get into all these things. We'll just focus on the iron deficiency anemia. So with this guy, he's had the prior history of the lower GI bleed, the poor diet. You're thinking iron deficiency anemia. What are some tests you're going to want to do? Yep. Yeah. The standard workup here that recommended is the student CBC. We're looking for hemoglobin. General for anyone over 1 year old, for any infant below 12 months of age, it's more time specific. There's a full big chart that correlates each age with their specific hemoglobin needs. Also, you want a blood smear, get a reticulocyte count, especially if you're thinking one of the less common anemias. Blood creatinine, serum iron, serum ferritin. So serum ferritin is the most specific. If it's below 10, there's not a lot of other reasons for your serum ferritin. For your ferritin, it's going to be below 10. However, it was very good at very specific for the iron or for iron deficiency anemia. However, if it's high in kids that are especially in chronic inflammatory stage, not a great one to look at because ferritin is also two-phase reactant, so it will be high when there's any sort of chronic disease present, and if there's any sort of hemolysis. Yeah. Yeah. Anemia. This was part of the workup they give. Just, I think it's more just the assess hydration status, assess kidney function, especially if the patient you're not exactly on a diagnosis of anemia. It's more just part of the work. So treatment of a general iron deficiency anemia would be starting on any dietary iron, iron-rich food, and limiting cow's milk intake. Oftentimes, cow milk has been given before 1 year of age can result in anemia. Parents often say that their child gets enough milk to support to look at the source where it's coming from, and if they're taking any formula, is that formula fortified with iron. In terms of supplementation, when prescribing iron, it's 6 milligrams per kilogram per day for 3 to 4 months, and often for kids especially, taking iron can have a critical side effect. We're taking it with vitamin C, just telling your patients have this, wash it down with orange juice. Should be something to help increase the absorption. And then it's important to go through their past medical history, go through what actually may be causing this. If it's a non-dietary, non-anticipated cause, stabilization, most definitely bleed. So treating underlying cause, and then unstable, giving transfusions. So I guess treatment for the iron deficiency anemia is making sure it never happens in the first place. So breastfeeding or iron-fed formulas and milk before 1 year of age, introducing red meat and high iron content vegetables early, and preterm infants need supplementation with fed human milk by 1 month of age until they can be fed an iron-fed formula. So for this guy on CBU, didn't have the complete resolution of his case, but he was given 2 units of packed red blood cells on the floor. Hemoglobin gradually went up. He wasn't tachycardic anymore. He'd been stable for about a week. An MRI was done. He was found to have pancreatic cirrhosis and portal artery hypertension, which caused some varices. So we thought maybe we have a pulse of GI bleed. So we followed up with GI solution. Any questions?
All right, everyone. So I was assigned to talk to us about an approach to lymphadenopathy. So to get us started,
Here's what a lymph node looks like. I completely forgot what they actually look like, but essentially they're a meshwork trabecular structure, which will take ultrafiltrate from an active lymphatic vessel and sort of sift it down until it eventually reaches a lymphoid follicle where B and T cells are able to sort of sort out what's going on there and mount an immune response if they find any sort of pathological entity. The filtrate then sifts out and enters an efferent lymphatic vessel. You'll also notice that lymph nodes have their own vascular supply, which makes sense because all those blood cells are hungry themselves and they need their own nutrients come if they're going to do the work that they try to do. By definition, a lymphadenopathy is a disease state in which lymph nodes are either larger, harder, or just in bigger number than you would normally see. And so that's the topic that we're hitting. However, just because I call it a disease state, I'm not trying to say it's a negative state. And so the approach that we're going to try to come up with today is to give us the tools we need to determine if a lymphadenopathy is pathological, indeterminate, and in need of more investigation, or non-pathological. Because realistically, as you encounter viruses, your lymph nodes will mount responses and will grow in response to that. And that would be an example of a non-pathological lymphadenopathy. Furthermore, our approach is then going to direct us towards how our findings from a lymph node exam will sort of further settle how we ask questions and what kind of investigations we want to order. So that's going to be kind of our goals today. I've split up our approach into what I call phase A and phase B. They don't necessarily have to happen in this way in real life, but I thought it would be best to teach it this way. Phase A involves our actual lymph node exam and the way we're going to describe our lymph nodes, while phase B is sort of our response to our lymph node exam. Ideally, you would do sort of like a full history beforehand, but you'll notice things like directed history questions. Those would be things that maybe you forgot to ask because of the lymph node findings you have queued into and now want to ask. So, step one, localized lymph node. After you find one lymph node on a person, you kind of are obligated to look through the rest of the superficial lymph node regions in the body. Your goal is to record and organize the lymph nodes based on their anatomical location. So after you find one lymph node, say at the start of right in front of the ears, you're going to want to make your way through the rest of the face. Record maybe you've got some more underneath the mandible, maybe they're down the anterior chain of the neck. This is a great moment for some interaction. So who can name some of the lymph node chains of the face and neck? Green post-radicular, good one. Anyone else? Submandibular, yeah. What else? Submental, good one, good one. Where else?
Super and infraclavicular.
Yeah, super and infraclavicular. Yeah, do we have one here?
Yeah.
Occipital, and what about my neck? Yeah, good work. We call those the cervical chains. So based on what's happening on those lymph nodes, we're draining different parts of the head and neck. And what's kind of nice about it is that essentially if you tilt your head up like 30 degrees, you just like gravity do all the work. So tilt your head up and all of the stuff from your ear is going to drain down and it falls into your post-auricular chain. All the stuff from your eyes goes to your pre-auricular chain. That's why I need to talk about lymph node exam for Jake today. And that kind of just works everywhere. And you'll also notice that things drip down. So post-auricular, we've got some aortitises there, but they also drip down to your posterior. And that's common that you'll find these findings in sort of contiguous chains. What other superficial lymph nodes are there? Yeah, axillary. What else? Inguinal, yeah. Inguinal can be divided into two sections, a vertical and a horizontal inguinal. It doesn't really change much based on if they're horizontal or vertical. We just like to specify it. And is there any others that people know about? What's here? Yeah, the trochlear. And what's here? Yeah, popliteal. Yeah. So these are some other regions, and they have their own sort of diseases. So as you can imagine, we're looking at pathologies of the vulva, or like prostate cancers can appear here, or even sort of STIs can appear on our inguinal chain. And our sort of brachial is commonly known for the breast exam, while the trochlear can do sort of skin lesions of the hand, or it can often be a sign of a sort of lymphoma or ALL.
pictures of them and like grab them by the elbow.
Yeah, that's it. I forgot that story, but it is true. I've heard it before. Essentially, you would grab that way, and you can tell someone's been naughty because of the way syphilis spreads throughout the body. So, you found a lymph node. You've searched the rest of the body for other sites. And what that does is lets you determine if you have a generalized lymph node lymphadenopathy or if you have a localized lymphadenopathy. So regional or localized lymphadenopathies are probably just reactive. These are our less pathological entities, and that's kind of what we're hoping to see. We define, if it's a generalized, it's probably some sort of systemic interaction is going on. We know it's generalized if you have 2 or more lymph node chains that are non-contiguous. You do have to do some little workaround because you could just have 2 localized reactions happening in the body at different locations. You still have to do your due diligence. Whenever you find a lymph node, you want to try to find the foci of its disease entity. So my post-auricular, I'm checking inside the ear. My pre-auricular, I'm looking at the eyes, that kind of stuff. My anterior cervical, looking in the throat. Next, I want to quantify my lymph nodes. And you can quantify them in a couple ways, but essentially, when I say quantify, I mean I want numbers. So you're going to look for the size of the lymph node. You can kind of gauge that with your fingers, with a ruler. You also want to get a number. You want to see how many are inflamed, get the average size of these inflamed lymph nodes. Things like that. You do need to keep it in context for both age and location. So, if you had to guess, who has bigger lymph nodes? Young people or old people? Young people. No, it's true. Young people have it because they're more reactive in general, right? Everything's new. They don't have this sort of mature, responsible immune system. So they're just constantly flaring up. They constantly have big lymph nodes. We don't react as severely to a large lymph node in a child in an acute phase of illness. What about where do you think in the body is the biggest lymph nodes that you can palpate? Inguinal, yeah. Inguinal lymph nodes are often 1.5 centimeters in a non-inflamed state. Cervical lymph nodes are often 1 centimeter on a non-inflamed state. And some of the other ones, like our clavicular or trochlear and our popliteal, are about 0.5 on average. So you have to keep in mind when you palpate them, what size they are relative to what size you'd expect them to be. Next, you want to describe the lymph node. What kind of texture is it? Is it soft, rubbery, or hard? Those all sort of indicate how far along the disease process has gone. Is it painful to touch? Is it in a fixed location? How long has the lymph node persisted? If you guys had to guess, what signs are bad out of these qualities?
Hard.
Yeah, hard. Fixed. Non-painful. So it's interesting because all of that is sort of relative. Non-painful doesn't always mean cancer. It just often means something more nefarious is going on. Hard doesn't always mean cancer. It could mean a chronically inflamed lymph node from repeated infection that's become fibrosed. So it becomes hard and you can feel it all the time. And if it's fixed in location, it doesn't necessarily mean that it has malignant cancer cells branching out and invading the sarcoma underneath. It could just be sort of the inflammation process has prevented motion within the subcutaneous fascia. So all of these things we do look at, and it does increase our risk that it's something nefarious, but it's not a hard and fast rule. So that's phase A. Now we're going to go to phase B. I've got another activity for us to go. So I've got questions that we would want to ask based on lymph node findings. So in other words, you know you're going to ask a constitutional symptom. What lymph node findings do you think brought us to this question? Yeah. 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 It could also be there for a long period of time. It could also be generalized. It could be many lymph nodes. Or you could have a matted structure. You get like several of them that have actually combined together and they move as a big ball. Yeah. What would make you ask about dental symptoms? Yeah, submandibular findings. Good work, everyone. Everyone's kind of going like this. What about animal exposures? Animal exposures are really common for sort of part of your epitrochlear lymph node workup for cat scratch disease. You can also, prairie dogs, interesting enough, the Canadian source of bubonic plague. So be careful, you'll get buboes, which are actually just weirdly inflamed lymph nodes. What would make you ask about meds? So for meds, you're looking at a generalized lymphadenopathy because the whole body is reacting because meds kind of get everywhere. And the same thing would happen for autoimmune diseases. So next thing I want to talk to us about is empiric treatment. Essentially, if you found yourself in a localized lymphadenopathy situation, the average way to react is essentially to find the foci of disease and treat it, and then look at the lymph node 4 weeks later. At that point, you'd expect lymph node, if the disease has been properly treated, to have disappeared. If it persists, something more must be going on, and it'll lead you to take more testing. However, you don't always get localized findings, you get those systemic ones, and maybe you can't find meds that are causing it. So now you're kind of ruling in things like malignancy or rheumatic diseases and other sort of generalized full body pathologies, even viral pathologies need to be ruled out. In this case, you're going to have a series of investigations you might want to run. CBC with differential and CRP is good for knowing if the body's in a generalized inflamed state. Good to kind of increase your intuition for ALLs and lymphomas as well. Serology for CMV and EBV, really good for working out some of those viruses that can cause generalized lymphadenopathy throughout the body. Tuberculin skin test, because tuberculosis can cause lymphadenopathy in a lot of weird places. A chest x-ray is often recommended because you're worried about mediastinal masses. And an ANA helps you determine if this person has some sort of rheumatic condition going on. Does that make sense, everyone? Nice. And then the gold standard is the excisional biopsy. We want to eventually take out that lymph node if it's there for a really, really weird situation. Here, I've got 5 red flags that almost always mean you're going to do an immediate excisional biopsy. So if you see constitutional symptoms, you're really worried. You're going to take an excisional biopsy of the largest, most abnormal lymph node you can find in the person. If they've got a mediastinal mass, really concerning finding. You're going to find a lymph node and you're going to biopsy it. If they have one lymph node that's greater than 4 centimeters, that's huge. That's crazy. That's weird. And if they have a chain of lymph nodes that are all bigger than 3 centimeters, crazy and weird. Yeah. Not like just multiple. Multiple 3 centimeter lymph nodes in a chain, so just something big is going on there. And then supraclavicular, infraclavicular, and epitrochlear lymph nodes, all drain regions that are known to be sort of metastatic points. And so that's why we like to excise those ones. It's really interesting. The left supraclavicular drains to the abdomen because of the way the body's blood vessels work. It's called the Trozier sign, something along those lines. There you go. Thanks, Arch people. All right, so I've got some cases. This is where we test whether my approaches work for us or not. Because I haven't explained every nitty-gritty detail. We're going to see you guys to make the jump to like rule in some stuff, the questions you want to ask based on our lymph node approach. So case 1, teenage girl comes in with new onset, palpable lymph nodes in the inguinal region. What's your approach? Yeah, cool. I like it. What kind of physical stuff are you going to look at? Okay, sure. I was really hoping someone would say localize, quantify, qualify. But okay, sure. You do your own thing. Don't pay attention to me. What are your specific questions that you're going to want to ask this girl? Exactly. And so I find teenage girls always open up to me. And so she tells you, she recently started seeing the football quarterback in school. She didn't think anything was going to happen. She thought it was just Snapchat flirting. But one day at a party, it became much more. What else do you want to ask? Yeah, did you use protection? No, but he pulled out, so she's fine. Also, she's in the middle of her period. What else do you want to ask?
Any other, like, really sexual history?
Yeah.
Any urine?
Yeah, exactly. Have you had your testing yet?
Any symptoms like burning?
Burning when you pee. Weird discharge. Totally. This girl has gonorrhea/chlamydia. You guys figured that out based on her lymph node exam. Good work. Case 2, a 10-year-old boy comes with bilateral lymphadenopathy of the cervical chain, fever, and lethargy. What's your approach? Localize, quantify, and qualify. Good work. What do you guys think this guy might have? What are some specific investigations? Yeah. In the throat, you find a lot of pus. Or, instead of strep throat, maybe. No, the virus. Yeah, exactly, mono. Mono presents this classic triad of lethargy, fever, and cervical chain. It's not always bilateral, it's often unilateral as well. Cool. Case 3, 9-year-old boy comes in with large swollen lymph nodes on the anterior cervical chain. What's your approach? Yeah, is someone going to say it loud so I can hear it? Perfect. Okay. So you want to look at this big lymph node chain. It's huge, it's big, it's red, it's inflamed, it's ugly. What's going on? Yeah, this is actually lymphatic adenitis. It's an infection of the lymph node itself. So these are sort of our tender lymph nodes. That's what we talk about when we talk about tender versus non-tender. Usually if I have like an ear infection going on, behind my ear isn't actually tender on the lymph node. It might be just because of the mastoid process, because a lot of pressure, but it's not the result of the reactive lymphadenopathy. This is like tender one. This is because it's swollen in such a fast time, it stretches your capsule. Yeah. Yeah, so you've got a couple of options. You could try the conservative approach where you just do medications. This guy's is really bad, so I probably wouldn't want to just do medications on him. Maybe I do IV medications on him and hope that works, but probably I'd want to do an incision and drainage. Depending on if you've got an ultrasound, you might be able to do sort of an ultrasound-guided fine needle aspiration. But that's fancy stuff. No one really does that. Everyone just cuts it open, lets the pus drain. Yeah. This you leave a second intention healing after 2, because if you close it back up, you'll just abscess again. Okay, case 4. An 8-year-old girl presents with fever and swollen lymph nodes. What's your approach? Yeah. Yeah. Good work. And so in her case, what you find is that she has a large sort of matted set of lymph nodes. She's got some supraclavicular and infraclavicular lymph nodes as well. On the left or right side? On the right side. Yeah. Yeah. Yeah.
And she has the groups that are possibly 1%.
Yeah. And they're matted. So they're hard to get a good size on. Yeah. Chest X-ray totally. She has a mediastinal mass, which isn't looking good, guys. What do you think she might have? Yeah, she has a lymphoma. Good work. Other tests you might want to order for the workup of lymphoma, the lactate dehydrogenase. You want to do that for any cancer suspicions you have.
What does that actually tell you?
It tells you if cells are kind of exploding. That's yeah. Beta 2 micro something grams. Serum calcium. You want a peripheral blood smear, and you want hepatic and renal function because you're going to want to know if she can take chemo. Yeah. So you're also going to want some other electrolytes to see if you've got tumor lysis syndrome going on. Especially once we start chemotherapy, there's a big chance that she's going to get flooded. Just before a day. Yeah, so tumor lysis syndrome is often occurs secondary to a tumor disease, I guess, a cancer disease. Essentially what happens is the contents of the cells explode as your body fights the tumor infection. And what that does is it floods your body with potassium, that's the most dangerous one. Also floods your body with calcium, which can drop the phosphate. Other way around, floods your body with phosphate, which can drop your calcium by binding to it, and a couple of other electrolytes that we watched for. You get bone stuff, and it also predisposes you to more arrhythmias because of the low calcium.
So like basically the tumor cells are turned over, so they spontaneously get bigger. So you get basically the blood that binds with calcium. It would be rare. You very high or that be something massive. Unusual for them.
Pop quiz. What do you guys think we do to help with that? Yeah. Exactly. 200% maintenance. Well, thank you everyone for participating so well. Sure. Address.
Yes, sir. I think that's
No, I thought you know.
Visual standpoint. Thank you.